Okay, welcome everybody, and thank you all for joining this important and timely discussion. And first of all, I think just the fact that we're now up to discussing this topic tonight is not yet a sigh of relief, but it means that we're already moving out of the lockdown phase, and children are starting to go back into our schools, and that's why this conversation is so timely. I also think that for a lot of parents, grandparents, family members, it's a topic that we're so grateful to have Dr. Karyn Moshal helping us with this evening, because there's so many emotions involved in it. There are so many different voices that are out there. There's government policy, the educational psychologists that are speaking out, there's friends, there's parents, there's kids going stir crazy at home, and all of these things are going into the mix, and often it's difficult to see the wood from the trees. So I even just personally am very looking forward to hearing the presentation. We'd really like to encourage questions and discussions. So after Dr. Moshal's presentation, please do feel free to ask the questions, whether it's by putting them at that time in the chat box, and we'll be able to hopefully deal with them, or by asking the question at the time by unmuting yourself. And finally, I think that, whilst I'm not sure in terms of the audience, probably it may be that there are a lot of parents and family members. I think that also, just in terms of general interest, going back to school is in a way the marker of us making a bridge from lockdown back into a transitioning society. And so this discussion is pertinent in and of itself, but also in the way that it branches out into the larger picture of infectious diseases, and moving from COVID back into interacting with society as a whole, etc. So I'm going to hand over now to Dr. Karyn Moshal, who's the Doctor of Infectious Diseases Paediatrician at Great Ormond Street. Thank you.
Myself. Thanks for being here on a Thursday evening. I know that it's time when people are probably preparing for Shabbos and getting kids to bed, but thanks for joining me. Let me just sort out my slides. I've just put together a small PowerPoint presentation so you don't have to look at me all the time. And you also, I can have an aid memoir and just stay on subject. As Lauren says, I'm a pediatrician at Great Ormond Street, and I'm going to speak not from a teacher's point of view and an educationalist point of view, but from a medic's point of view. And I want to try and put this in perspective for everybody so they can feel more comfortable with what we're actually dealing with, because I think that in all the noise of social media, of politics, we've lost sight of what is really important and is central to all of this, which is our kids and the next generation. So I'm going to start rather with a wider picture, and then drill down to why I think my opinion is what it is. And I can tell you now, so those of you who want to short circuit it, the headlines are, I think children should go back to school, and they should go back to school as soon as possible. And I'm going to share with you why I think that. So if I can get my slides working, just to take a step back and get some perspective on this. We're in the middle of a pandemic, which for many people is the first pandemic that has directly affected them. But actually, pandemics are a fact of life. They've been occurring down the ages and have actually changed the course of history. They have changed what we do and how we do things. And a lot of what we take for granted now actually is a result of pandemics that have gone before. For example, quarantine, and the concept of quarantine comes from pandemics in the 1500s. The concept of vaccines comes from the smallpox pandemic, which drove the production of the first vaccine, which was the smallpox vaccine. The HIV epidemic, which is within our lifetime, has driven us to think a lot more about how we function as society, how we deal with discrimination and stigma, and how we treat people who are other. So there've been lots of changes that pandemics have driven, and they drive those changes very, very quickly. And it's been true in medicine as well. We currently are profiting or benefiting from the HIV epidemic, in that a lot of what we know and what we are using to develop vaccines and new drugs, that technology was developed during the HIV pandemic. So the question is, what is the shape of this pandemic going to be, and what is it going to do to us as a society and to our lives? And we all have both a responsibility and an ability to help decide what that's going to be. We know already that it's driven huge change in social media and in technology, and we know that also it is healing our planet. This might be the green pandemic that we are seeing now, with a decrease in pollution and an increase in wildlife. So those are the positives. But the question is, what impact is it going to have on us as a society and our children, who are the next generation? And I think that it is going to be profound, and we're in a very dangerous time at the moment for our children, but not necessarily for reasons that we might think. So to talk a little bit about COVID-19, or the virus that causes it, which is SARS-CoV-2, it's an envelope virus. And this is really important because we know that envelope viruses break down very quickly. And once the envelope is gone, they're no longer infectious. So that tells us that really, once this virus is out of the body, if it's been on surfaces for a few hours, it is unlikely to still be infectious. We might be able to find the virus and to find the RNA, but it doesn't necessarily mean that it's viable. And that's something that we need to take into account when we think about risks and risk benefit of different things that we do. It's part of a family of viruses that we've known about since the 1960s. They were first discovered by Jean Almeida, who's a British scientist. And there's a range of severity. A lot of our common colds are caused by coronavirus, so it's not unknown to us. This one is different because it's new. And in terms of severity, it falls somewhere between the cold viruses and the viruses that cause SARS and MERS, which occurred in 2003 and 2005, which were a little indicator of what was coming. It is more fatal than influenza, but we have to look at that risk quite carefully, and we need to be careful about how we interpret the numbers that we are seeing, because we don't know how many people have been infected and got completely better from it. And that would give us a much, much better idea of how severe it really is, because we only recognize and see the more severe end of the range, which can give us a skewed picture. We think it has an infection ratio of about 1 to 3 people, which makes it less infectious than influenza, but more infectious than bacterial infections such as strep throat. And it's spread by droplets. And what this means is that in order for a virus to infect you, you have to inhale a droplet that somebody else has spewed out, which is different to the virus hanging around in the environment and in the soil, and in the air, which would make it more infectious. So let's look at the things that we worry about as parents, as grandparents, as members of the community. We worry about COVID-19, we worry about the infection, how it will affect us, how it will affect our parents, how it will affect our siblings, how it will affect the vulnerable people in our family who might have chronic infections, how it will affect our children. We worry that it will spread without us knowing from somebody who might be carrying it. And how do we know? And there's something a little bit Talmudic about this, because we know that COVID-19 is infectious from about 24 hours before the symptoms appear. So people are very concerned about this. They go, well, we could be passing it on. Well, if you've seen somebody and you haven't developed symptoms, either you're asymptomatic, which decreases the likelihood of you passing it on, or you weren't that infectious at the time that you saw this person. I'm not saying that we need to be cavalier, but we need to actually quantify the risk. Now, the other thing about this is it's not that different to other viruses. Varicella virus, which causes chickenpox, for instance, is most infectious before the spots come out and before the child becomes unwell. So there are lots of things about this virus and its behavior that are quite familiar to us as medics. There is concern that this virus will spread from children to their grandparents, who are the natural caregivers for a lot of children when their parents are working. But I'm going to talk a little bit more about this. That is very disputed, and although it feels uncomfortable for us to say that's not the case, actually there's growing evidence that it isn't the case. We are worried about picking up infection from peers, for our children picking up infection from peers at school or at work, and we're concerned about children with chronic infections. And finally, right at the bottom of that list, which has fallen to the bottom of the priority list, is accessing care for other things. Now, the next slide I'm going to show you is going to show you that actually, as a pediatrician with my pediatrician hat on, we worry about quite different things when it comes to children. We worry about providing a safe environment for children who are unwell, whatever the cause. We are worried about children not accessing treatment safely and in a timely fashion when they need it, rather than when it's almost too late or too late. We are worried about the communications that are going out to families about accessing care. And we're worried about maintaining a safe pediatric service for children and identifying those children who are at risk for whatever the reason is. And then further down our list of priorities is COVID-19. And the reason for this is because we know that children are either asymptomatic or have very mild infections when they become unwell. And this is evidence that came out of China. And we said, well, are we sure we can believe the Chinese? They had 82,000 people. How many children did they have? They had far fewer children in their cohort. How do they really know? They've talked about a few children. Italy, well, maybe they don't have that many children. They did not see a huge influx of children into their A&Es, never mind anywhere else. And that is the same thing that has been seen in the United States, that has been seen here, and that is being seen everywhere else. So our problem is not really children who are presenting with COVID-19. Our problem is children not coming in for other things. Now, when we were looking at this at Great Ormond Street, we looked at how we could provide a safe space for children who are unwell for other reasons, because we had the evidence from China and from Italy who'd gone before us. And what was done, which is obviously widespread knowledge in the medical community, but perhaps less so outside, is that North Central London services were rearranged. So while hospitals were increasing capacity for adult patients, what was happening is that pediatric patients were being diverted to Great Ormond Street, where for the first time ever, we opened a general pediatric service, which was run by pediatricians who were transferred from those other hospitals to look after children within the Great Ormond Street setting, which was a huge piece of work. And took an enormous amount of effort from a lot of people, but has worked extremely well. So we have been seeing children, not just children with other diseases, but children from the community who would present generally to any A&E. We've also had the children we normally look after, the children with cancer, the children with immune problems, the children with hematological problems, all those children who we think of as being very, very vulnerable to getting infection and becoming very, very ill with those infections. And we have had some of these children through the hospital who have been tested for COVID-19, and they've been tested because they're coming into an environment that needs to be a clean and safe environment for children who are COVID negative. And so we have an infection control policy that means everybody is tested. And what that means is that we know children who are asymptomatic, but who are positive. And we've had quite a few children who have come in who've had other underlying problems, and have coincidentally been positive for COVID-19, but haven't been unwell with it. And that is a very, very reassuring for us when we think about how we plan for children and how children are looked after. Now, the other thing that you might have seen in the press lately, which has been a huge amount of attention around a disease we're calling PIMS-TS, which is pediatric inflammatory multi-system disorder temporally associated with SARS-CoV-2. So now you know why we call it PIMS-TS, which is easier. And this is an extremely, extremely rare post-infectious reaction to having had an infection. Now, we postulate that there are tens, probably hundreds of thousands of children who've had asymptomatic infection that we didn't know about. So we need to quantify the risk in those terms. And we've had perhaps a couple of hundred patients across the country. Speaking to colleagues in the States, up and down the East Coast, in Boston, Philadelphia, and our colleagues in Bergamo in Italy, they've also seen small numbers of children. New York, despite their huge, huge epidemic, I think they had something like 15 in their initial group of patients. So it is extremely rare, and it's not something that we need to be concerned about, but I'm going to just give a brief summary of what it is, just for your interest and information, because for us as medics, it's been a very fascinating process that we've had to learn about very, very quickly and learn how to treat literally as the patients were coming in the door. And it's a syndrome where children present with an exaggerated response to the virus, and they come in with high fevers, they come in with tummy pain, with diarrhea and vomiting. Some of them have rashes, and some of them are in shock. They present around the age of 9 to 17, with the average age around 13. And although they, in the early days, were very, very sick when they first came in, we very quickly figured out how to treat them and how to turn them around. And that was incredibly satisfying, because these kids got better within sort of 3 to 5 days. Now, that surge, which happened approximately 4 weeks after the height of COVID infection across London, so that's about between 2 and 4 weeks is how long it takes for this to present. That's slowing down. We have a trickle of patients, and they're not nearly as unwell as they were when they first came in. And it's very possible that the reason for this is because they're presenting earlier, it's being recognized earlier and treated earlier. So this is a very, very rare complication. And again, to put it in context, every year when we have our flu season, we do see some children who are extremely ill from it. Children very rarely will become, some children, few children will become ill from other diseases, because diseases are all a spectrum, but this is extremely rare. So we need to think about how, within the context of this information, how we keep our children safe. And the question for me is, keep them safe from what? Because in terms of COVID-19 infection, they're not at huge risk. We also know, in addition to the fact that they either have asymptomatic or mild infection, that a lot of them seem to be almost resistant to infection. And I just saw a study yesterday that came out of Israel that was done in Bnei Brak, looking at households, and it was done deliberately in Bnei Brak because it's a very, very dense population with a lot of overcrowding and large families with lots of children. And it was very interesting because it showed that where 2/3 of the adults in those households might be infected, for children under 5, less than a third were infected. And for children between 5 and 17, about a third were infected. In fact, it was less than 10% in the under 5s, which tells us that infections go from adults to children. They do not go in the other direction. And children are, to agree, and we don't know why, do not seem to be getting it. It might be that they have very quick infections, 24 hours, and clear the virus before the test can pick them up, but we don't know. That's just pure speculation. So we know that our children in a school environment will not be at risk the way they might be for things like chicken pox, things like influenza, and the chance that they're bringing it home to their grandparents and to their parents is very low. There are other infections out there. Just because there's COVID-19 doesn't mean to say everything else has disappeared. And I think in our focus on COVID-19, we've forgotten that. And we also forgotten how we assess risk to those other infections on a normal day pre-COVID, which is something that we need to bring back in order to bring some context and some perspective to how we evaluate risk for our children. And I think that we will be looking at it differently, and the way and when we choose to send our children to school when they have infections of any kind will be different. At the moment, a lot of parents will recognize a slight cold, will send them to school because I've got an important meeting and I've got no childcare and it's okay. I think that we might be rethinking some of those things. How long children stay out after they've had an infection also might be different, but that does not mean that we should not be sending our children back to school. And the reason for this is that the non-infectious harm to our children is far, far greater than the harm from COVID infection. There is a loss of socialization, there's a loss of education. I mean, we know that there's a loss of education, but everything else that children get at school, they're losing. They're losing their routine, they're losing their ability to socialize, to communicate, to develop independence, to develop autonomy, all of which are really hugely, hugely important developmental stages in a child's life. And that is our children, a lot of whom are very privileged children. When you look at the greater society and you realize what an incredible lifeline school is to so many of those children and those families out there, you realize how deeply, deeply dangerous and destructive the lack of schooling has been. There are enormous safeguarding issues, and the potential for abuse that is going on behind closed doors is something that we cannot even begin to quantify, but we are incredibly worried about, because these children are not coming in. Schools are safe places for these children. They are places of structure, they are places of safety, they're places that give them warmth, that give them security. And by leaving them in family situations that are vulnerable, particularly at times of stress, like now, where those families are even more on the edge than before, is incredibly problematic. There was a letter that I think some of my colleagues in safeguarding sent to the BMJ over the last week, essentially saying this. That is before we talk about vulnerable children who don't have access to secure food sources, for whom school lunches are a lifeline and perhaps the only hot meal they get. Food is provided for some of these children, but they're getting a sandwich. And there are going to be lots of consequences to those nutritional issues when those kids get back to school. And then there are the mental health issues, and these are absolutely enormous. So many of these children rely on the structure, on the routine, on their teachers, and on the school staff to provide them with the structure they need, regardless of the families that they come from, to help them to manage their lives and manage their days. And you take that structure away from them and things fall apart. Add to which a lot of people are not accessing mental health services early enough because they think they're closed. And we have a major mental health crisis that is looming for our children. You go back to our population, to our children who, for the most part, have access to the internet, come from loving families who can support them. There are still the issues of isolation and lack of socialization and contact with their peer groups that will have consequences going forward. So when we think about the risks and we talk about the risks, it's quite frustrating to see in the press that it is all about COVID-19 and it's all about COVID infection, rather than taking a step back and looking at the bigger picture and looking at all the risks that our children face, and then balancing them and making decisions based on the bigger picture. I think that I can say I speak for most of my pediatric colleagues where I say, to a man, our view is children should be going back to school and as soon as possible. We need to balance those risks, and we need to think about which group of people are most at risk, and it's not the children, it's the teachers, and the teachers are at no greater risk than they would be in any other work environment, because it's the other adults in that environment that they need to be cautious around. And adults should be able to manage the social distancing that is required and the hygiene that is required. And certainly young children can be taught the hygiene rules that are necessary. So I think I'm going to stop there. I think that we need to start thinking about things differently, and things will change about how schools run, and how education is provided, and who is there. But it's an opportunity to make this work for those children, rather than against those children. Smaller classes certainly would benefit children who come from deprived homes, who are in large state schools with huge classes where they can get lost. So I think I'll stop there. I've probably spoken longer than I should, Lauren, but I'll finish, and I'm happy to take questions.
Can I ask a question?
Sure.
So thanks, a really, really fascinating talk, and I love the way that it sounds much more sensible than most of the things we hear on the news.
Good, I'm glad.
One thing I wanted to ask, at the beginning, you seemed to say that, that the children weren't so, it wasn't so dangerous, or you weren't so concerned about children spreading it to each other and then spreading it to grandparents. And I just wanted to double check that I understood that.
Yes. Yes, it's different. It's different to other infections. Now, I think that that is a different question to the question that I think you might be asking, which is, can our children see their grandparents? Because the grandparents are at risk. So you have to quantify the risk for them of seeing anybody, rather than children specifically, and anybody who's been out there. So I'm not advocating that you break the isolation rules that have been set in place for parents, for people who are over the age of 70, which are the vulnerable group. But I do think that this is a different discussion around schools and the risks of children in schools, but the children are not nearly as much of a risk to the adults around them as the adults are to each other and potentially to those children, but not that much to the kids.
Just to follow that on, so at the moment, if the children are in isolation, we've taken the view that it's okay for them to see their grandparents, yeah? But then if they go back to school, then
then you need to think again. You need to think a little bit more carefully, because it's not just your kids who are having contact with other kids and with teachers, but it's you as parents having contact with other parents who are collecting kids and potentially teachers. So you're essentially widening the number of people who you have contact with. And I think that the message is we just have to be sensible about this. You know, I've got my parents on this Zoom call, and my daughter was isolated for, I think, about 10 weeks. And I took the view that as she was isolated from everybody else, she could see my parents. Now that she started seeing other school children, we need to review that, because it's their safety rather than hers that is the issue. And I think that that's something that you need to think about when you're thinking about contact with elderly relatives who fall into that vulnerable group.
Karyn, I think there's a question in the chat from Michal.
Right.
Can you see it's asking about class sizes that you mentioned?
Okay. I spoke about classroom sizes. As I said right at the beginning, I'm not a teacher. and I'm not making those decisions. In this country, what they're talking about is class sizes of 15, no more than 15, so they can provide appropriate social distancing. Personally, I think social distancing for small children is both unnecessary and impossible to attain. And if we take that view, we will never send our kids back to school, which is absolutely devastating for them. Classroom sizes in Israel and South Africa, I can't comment on that. I know obviously South African classes are big, and that is going to be an issue. People are thinking about outdoor teaching, which again, a lot of very underprivileged children in South Africa have had for decades. Israel, I don't know. I think that when we talk about resources and using resources, we need to think about what lengths we go to sterilize resources, which is what a lot of people are thinking about. Again, it's an envelope virus. We need to be sensible. We need to practice good hygiene, and we need to keep our resources clean. But we also need to quantify that risk. So if resources have to be shared, well, leave them overnight in a classroom before they're used the next day by somebody else. And then you'll be fine. Because even if virus is found on cardboard or paper, it's unlikely to be viable 24 hours later. I said Michal is, what did she say? She said they're not really doing that here. Okay, I can't comment on that. I think every school is doing something slightly different, and they're all winging it.
Yeah, I mean, there's a comment here from Richard as well, just saying that, you know, they've also had schools opening and then schools having to shut again. There's sort of this, you know, it seems to be trial and error. And to kind of jump on the bandwagon, you know, in Israel, for example, they have seen a huge spike in cases after schools have opened. But perhaps that's, you know, a way of growing the herd immunity. Like, is that necessarily a bad thing? And then I would just add to that, that then what I see is, you know, on groups of parents in Israel with vulnerable children who had sent their children back to school, they all, you know, pulled their children straight out of school again. So there's also a price on that end. So if you could just comment on that.
Okay, sure, I'll talk about that. Firstly, I think we have to be very careful about how we assign cause and effect. Sending kids back to school is also a loosening of social distancing in other ways, and amongst parents and amongst teachers. So if they've seen a spike, and I haven't seen huge spikes from the numbers from Israel, the question is, where are those spikes and what age groups are those spikes, and how are they happening, rather than ascribing them to school opening, because it's not the children taking it back, it's potentially teachers spreading it amongst themselves. So that's number one. The issue of vulnerable children is much more comfortable ground, because this is what I've been dealing with almost ad nauseum for the last 2 months. And it's very uncomfortable for a lot of parents, and it's uncomfortable and has been uncomfortable for medics, because the advice we're giving completely flies in the face of the advice that might be given for other infections. So when it comes to vulnerable children, whatever advice you have been given by your medical team regarding general infections, not COVID-19, but general infection risk, you need to continue to follow those guidelines, because your child will still be at risk in the same way from those infections as they always were before COVID-19 came along. Now, when it comes to COVID-19, what we've discovered is actually those children who are in those vulnerable groups are no more or less vulnerable to COVID-19 than any other child. And in some ways, it's quite extraordinary, but we've got building evidence to show that. We've had quite a few of our hematology kids coming through, some of whom have been on treatment, who have been positive for COVID-19 and had no symptoms at all. There's a database on inflammatory bowel disease that has been put together across the world. And Dan Turner, who heads up the IBD unit at Shoret Zedek, I think he's either leading or one of the principals in that database. And they've had some children with IBD who are on treatment, who've had COVID-19. They've had no deaths, and to the best of my knowledge, they haven't had any hospitalizations, and neither have we. So, you know, we are telling patients something different around this disease than we did before. And we are just doing an exercise now where we're going back to all our patients, because Great Ormond Street has tens of thousands of patients, I think something like 20,000, who fall into a vulnerable group who are immunocompromised in some way. And we're going back to a lot of them and saying, you do not need to shield your child because they're no more or less at risk of COVID-19 than the rest of the population. So people will be getting information in the next probably month to say this is what we've seen in our populations. Obviously, there are some who still need to be shielded because of the very, very high doses of whatever that they're on. But we also, the flip side of this, you could say, well, those patients have been shielded, they've had no contact with anybody, and therefore, how do you know? But actually, this is a group who ironically have had more contact because they've had to come in and out of hospital for treatment. And despite coming in and out of hospital for treatment, they've still not ended up either infected or severely infected if they have been positive.
Hello.
Okay, hi, how are you? Yes, I'm just reading your long message. I don't know if everybody
all my questions
can read it. Okay. I think there are two things here. Firstly, in schools, I agree with you. I think that it's impossible to prevent 4-year-olds from touching each other. They will, and we just have to live with that risk because children will be children. I think that what we have to do is put sensible measures in place, make sure that kids understand the importance of washing hands, using gel if there's gel, as long as they don't drink it. Which was something. Okay, I'm not going to go there. I'm not going to go to the American story, but we need to make sure that they understand the basics of hygiene, and then we need to let them get on with it, because, you know, we know to our cost that children who are not allowed to grub around in the dirt and eat soil and play actually have much higher rates of allergy down the line. So we might be swapping one problem for another. In terms of medical problems. And then to come to your other question in terms of the psychological issue, I think that short answer is intuitively, I think yes. What message are we giving to our children about being warm and friendly and outgoing and caring towards other people when we are sending them a message that any child, any person other than themselves or their family might cause them harm? And I think that we have to be careful about the messages we give. We give messages about strangers which are appropriate, but when you're socializing in a group and friends, you need to build trust within those friendship groups, and you need to create that warmth. And I think that there will potentially be psychological issues down the line. We just don't know what they are yet.
I think the Leon family have a question.
Hi, Karyn.
Hi.
I wanted to ask you how your advice changes with children going back to school, dependent on how they get to school. So neither of my kids are in years that are invited back. The one that can walk to school, I would be delighted for her to go. For the one who has to take the tube into busy central London and go on 2 different lines and through busy interchanges, I feel much more nervous about. Is that fair or mad of me?
I understand as a parent what you're saying. I'm not a fan of tube travel for children anyway, so my answer is probably going to be colored to a degree by that. But in terms of COVID-19 infection, yes, your child might be at increased risk of picking up COVID-19 on the tube if it's crowded and if people are not wearing masks. But the question is if your child does get COVID-19, what is the risk from that infection? And how unwell are they likely to be? Because they could just as easily pick up flu when they travel in the winter. And it's again, it's about balancing those risks. So there are new guidelines that are coming out around masking, which has been fantastic not to have spoken about so far. So I can't believe I'm actually bringing it up. But the point of wearing a mask is to protect other people from you, rather than you from other people. Because if you have secretions that are infected, they're going to be caught in your mask. But if other people, but your mask is porous. So it provides a degree of protection of other people from you. So if everybody wears them, then there becomes a degree of herd protection. And I think that might be the way that things will go. And I think that you have to take a view as a parent, what the risks are, whether you would rather drive your child to school, whether you'd rather send them on a bus where the ventilation is better, but it might take longer. And it might be that schools will stagger their opening times to take that into account. But that is the planning that has to be done, because everything is a balance of risk. So I'm sorry, I can't give you a clear-cut answer to that, but.
Okay, I have a question, please.
Hi.
Hi. Or you could ride a bike, I wanted to say to the Leon family as well, but that's another note.
Yes, that's the other thing. That's possible, but that has its own risks. So balance.
Actually, two questions. I'll be quick though.
Yeah.
One, I was confused initially with this new rare disease that you are seeing coming in. Not so much of, but it's been in the. I think initially it was compared to, or actually sold as kind of Kawasaki disease.
Yeah, it was sold as Kawasaki disease. And I've never seen so much publicity about Kawasaki disease ever, as I did at the end of April when we pulled the trigger on this, and now. And just an aside, Dr. Kawasaki died today in Japan. So it's a sad day for us in the infectious disease community. But Kawasaki disease is a rare disease, again, a post-infectious inflammatory disorder that is very, very rare, that affects the blood vessels and can affect the coronary arteries in children, usually under the age of 2. And about 50% of our patients are under the age of 2, and almost 100% of them are under the age of 5. So when this group of patients started coming in with pictures that looked like Kawasaki disease, what we were actually seeing was inflammation. And the inflammation of vessels and inflammation within the body that was similar to Kawasaki disease, but it's a very, very distinct and different disease process, not least because it affects a much older group of children. And it seems to preferentially, and we don't understand why, it affects children from Black and Asian minorities more than Caucasian populations. We don't know whether this is related to communities where there was high circulating virus and possibly more infection, or whether this is a particular vulnerability and risk that we need to define and protect people in those communities from. And also a lot of those children are quite overweight. And again, we don't know why that is. But there are huge, huge levels of inflammation. But the number of children are very small. And the reason why it became such a big thing was that at the end of probably mid-April, we started seeing these children coming into our intensive care units And it got to the point where we just recognized that there was a pattern happening here. And because we communicate very closely and we meet regularly with our colleagues at St. Mary's and at Evelina, we had a picture, as well as nationally, the other teams across the country. We could bring it all together and talk about it and say, okay, we've seen some of these through our PICU. Have you seen these? And at the same time, the intensive care units teams are talking to each other. And we all went, yes, this is different. We haven't seen it before. This is something new and emerging that is happening. And on the 25th of April, we pulled the trigger with National Health England. And the definition was worked out by representatives of our team, Evelina and St. Mary's, so that our colleagues across the country could recognize it, pediatricians could recognize it. And it's becoming, the cases you see now are much milder. But it is very, very rare when you look at the population in total. I mean, we're talking about a few hundred people across the country, and we've got tens of millions of children. So that will help quantify the risk. It falls between Kawasaki disease and toxic shock. We see about 1 case in 3 million children of toxic shock and about 1 in 10,000 of Kawasaki disease. And this disease probably falls somewhere between, both in how it presents and in numbers.
Thank you for that.
Sure.
Finally, based on the evidence you've seen so far, what's your opinion on the whole getting antibodies test? I know everyone's been down to JDoc, and I hear that some say, we're sure it lasts at least a year, and some say it might not be a month. And I kind of feel, what's the point if I don't really know how long it's even going to last for?
Yeah, it's tricky. And we're still learning a great deal about that. We've got a very, very big study going at Great Ormond Street at the moment where we're testing all our staff. We know we've got a really good test. And what's very interesting is people who were confirmed positive for virus on a nasal swab, now up to a month and sometimes 2 months later have got no antibodies. They would have had antibodies a couple of weeks later and now don't have any. So the antibodies seem to have disappeared. And it looks like that in some people, antibodies are disappearing at about 40 days, sometimes longer. Now that doesn't mean that there is no immunity whatsoever. It might be that we either have a test where the immunity is below the level of detection of the antibodies, but if you were infected again, your response would ramp up very quickly because you would recognize it. That it's also an antibody response as opposed to a cell-mediated response, and the other cells of the immune system that might actually provide some immunity, but we haven't looked at those yet. And there are a number of research studies looking to see if there's what we call a T-cell mediated response to this. We also know that it is found on the surfaces, so surfaces of lung and gut, and it might be that we're looking for the wrong type of antibody in the wrong place, and that they're antibodies that last longer, that are different to the ones that we are testing for. So, sorry, it's a complicated answer to the question, but yeah, you can test, and if you're positive, great, but we don't know that that provides protection. And if you're negative, it doesn't say that you haven't seen it and you haven't had antibodies and it's gone now.
Okay, there's no point.
Yeah, but again, if you think about all the other diseases that we're exposed to, we don't go and check our antibodies to flu. We don't check our antibodies to enterovirus. We don't even check our antibodies to diseases that we've been vaccinated against. So we just need to be sensible in this new world and just be cautious about whatever we might get.
Yeah, thank you very much.
Sure.
Can I ask?
Hi.
Hi, Karyn, congratulations on pointing out what has been so kept away from the public so long. That is,
Which is?
the fact that the children are not really at risk from going to school, certainly young children. And
Yeah.
the Dutch have already sent their children back to school a month ago.
Yeah.
As far as I know, there's no evidence that this has increased the risk.
Mm.
And they are not social distancing at
Yeah.
all.
Doesn't
And
surprise me.
secondly,
They're more sensible than the adults.
sorry?
They're sensible. Kids are intuitive.
Exactly. And I was going to ask you about the pinprick test for antibodies,
Yeah.
which is temporarily suspended, whereas, of course, blood taken in the veins is still being used to do antibody tests. My daughter, who's an NHS doctor, has had that, and I'm glad to say she is positive for antibodies.
Yeah. Yeah.
But do you think the pinprick technique for checking whether we have antibodies is going to come back, or do you think there's something wrong inherently with taking the blood from that method?
I think it might come back. I think that it's not necessarily how the blood is taken, rather the technology behind it and the analysis of that blood that is potentially problematic. You know, there've been a number of tests that have been tried and have failed because of the false positivity or the false negative rate, and this is one of a family of COVID of coronaviruses. So we didn't really look very hard at the pinprick antibody test when we developed ours at Great Ormond Street. We went straight to a venous sample, and we used the Abbott one. But I think that part of the problem is that some of these tests in general, and I'm not sure that it's only the pinprick test, but I suspect that this was the reason why it was problematic, is that either they're false negatives because they're not sensitive enough, or they're falsely positive because they pick up other coronaviruses in the family and don't distinguish the novel coronavirus COVID-19 from the other coronaviruses, which cause coughs and colds and regular respiratory infections that have been circulating for decades. But I think that it will come back. And, you know, we're very early in this whole process. If you think about it, we first heard about it in January, sort of end of December, beginning of January. And the fact that we have, number one, isolated the virus, sequenced the virus, we have a test to find the virus when you're infected. And now we have a test that can potentially look to see if you have antibodies to show that you've had the virus in the past, is quite an extraordinary time frame. If you think about it, if you think back to the last pandemic in our lifetime, that was HIV. This is the benefit of it, because it took years to get an HIV test. It took years before that to find the virus that was causing the strange new syndrome. And things have happened very, very quickly. Now, in the HIV world, there are dried blood spot tests that are used for babies that are very accurate, that are PCR tests that look for virus and also that look for antibodies. So I think that a pinprick test that can be done at home probably will be validated and accurate and available, but it might be a few months down the line before that can be brought back.
Thank you. Just a final question that's come up in the chat actually from a colleague at Gosh is with regards to, can you see it? It's with regards to the difference in infection, that there's clearly a differentiation between the severity of infection in children and adults, but at what point does that change? Is there a particular...
Right, it's gradual, and it's a gradual increase in risk, where under 19, I think its mortality rates are something like 0.5% or 1%, and then they go up slightly until you get to the sort of over 80s, which is about 14%. But then that's related a lot to comorbidities. You know, in children, we're looking at probably, I think it's even less than 0.5%. I know I'm 1.3% is my risk in my 50s. So it's gradual.
1.3%.
Fantastic. Thank you so much. Maimonides always spoke about the the power of the golden path, the medium. And I think that's one of the greatest things that's come out of this evening, is a sense of balance and the need to be looking at a holistic picture, you know, and the less black and white and more being able to see the nuanced picture. And I really just want to say a massive thank you. And just one thing that I found so touching was actually when you reached out to us, and you know, you've been so busy at Gosh with policies, and as you've been saying, you know, been dealing with things as they've been coming in and it's all new, and to then also find the time and say, you know what, if there's a half an hour to breathe, and I'm happy to be able to come and take people's questions. And I think we were really touched by that and so appreciative, and this evening's been really informative, and there is a recording of it, so hopefully other people will also be able to benefit from it. And as you said at the beginning, that, you know, those moments which were so satisfying when you found that, you know, what you were doing was working and you could see the difference, that patients were getting better. Please God, that should be the trajectory of everything that you do.
Yes, let's hope, and thank you very much, and just thank you for all you're doing for the community. It's been, you know, as I say, I've had to watch from a little bit of a distance because things have been so busy, but it's amazing. It's been really, really impressive. So I'm delighted to do what little I can.
Thank you so much.
It's a pleasure.
Thank you, Karyn. Thank you.
Pleasure. Bye.